All right, so let's look at these respiratory emergencies right quick. Shouldn't take a great deal of time because we're skipping over the anatomy and physiology. This is something that if you're lacking in, like what's the upper airway, the lower airway, in the diffusion process, and the pieces and parts, and how diffusion works, and how inspiration and expiration works, then go back and review that physiology chapter that we went over, okay? Because that's where it all is. We're past the anatomy and physiology. We won't go back and review that. So let's look at the breathing problem. What we have to first of all look at what's adequate. Is the patient breathing the way the patient's supposed to be breathing? Is there adequate respirations? So just like it says here, no sign of distress. As I look out here, I don't see any sign of respiratory distress, right? Then you all can have the ability, or you should have the ability to speak in full sentences like I am. Because when you measure someone in respiratory distress, you measure how many words they're able to say before they take a breath. That's how you gauge that. Like on chest pain or pain on a scale of 1 to 10, a respiratory emergency is gauged on how many words the patient can speak before they take a breath. All right? So obviously I'm not having any respiratory distress, and the skin color is normal, warm, pink, and dry. Normal mental status. They're alert to person, place, time, and event. So if that's adequate, you won't know what's inadequate unless you know what's adequate, right? You don't know what's wrong unless you know what's right, correct?
Yes.
So you have to have that sort of foundation there. So the other thing that we look at is the normal respirations. You should have equal bilateral rise and fall of the chest. Normal adult breathing is 12 to 20 breaths per minute. Make sure that in your notes you put a star by these. You have to know these normal respiratory rates. We already know the adult, but for the child, 15 to 30, and the infant, 20 to 50, if we don't know those respiratory rates, once you get into the scenario-based questions, they're going to be asking you, they're going to be giving you vital signs. So they'll give you a respiratory rate of a child, and if you don't know what's normal, you may think that respiratory rate is too fast. I can't tell you how many times I've been up at 3 o'clock in the morning-ish, going to someone's house, newborn baby's breathing 40 times a minute, and mom's freaking out. I don't breathe, mom's going, they're breathing so fast, I don't breathe that fast. And we get in their house early in the morning, we say, that's because you're not a baby, you're an adult. And you didn't pay attention in those baby classes when you left the hospital, right? Because their normal rate is, they're breathing within their normal rate. And there's nothing wrong with the baby. The baby's not in respiratory distress. And you don't hear any abnormal lung sounds. Any like a expiratory wheeze or something. So that's what is adequate. Remember, in the pediatric patient, they have a smaller airway, can be obstructed very easily. The tongues are huge. They grow into their tongue. Trachea is more flexible. That's why we have to leave them in a sniffing or a neutral position. And they're belly breathers. So they will breathe with their bellies. Adults are not belly breathers. You should see a pronounced movement of the abdomen when an adult is breathing normally. That, in adult, is called an accessory muscle. They use the abdomen as an accessory muscle to help them breathe, to help push air in. In a pediatric patient, they're normally belly breathers. So this is a good picture. They try to get this guy to look like he's having trouble breathing. You probably can't see it with the light on, but you notice how he's sort of diaphoretic. They made him a little pale somehow. Maybe they just went on the street and found some guy that was pale. I don't know. But anyway, he's a little pale, and he's tripoded. This is a good picture of a tripod position where the patient's sitting up and they're sort of trying to expand their chest cavity out to get more air in. Remember, the larger the cavity, the more air that can come in due to the decrease in pressure. So you walk up on him, you make your good general first impression, and you say, you may not know right away if he's having any respiratory problem, but you can look and say, something's not right. So then you go from there. Then you start in on your assessment. So it is a subjective perception, whether or not the patient's having trouble breathing. I've been called out many times to people's houses. They say, I'm having trouble breathing, but they're speaking 100 words before they have to take a breath, and then they're yelling and cussing at their family members. And it's like, I don't think you're having any trouble breathing. When you're moving adequate air enough to shout at your family. So it could be a perception, but one thing that you may look at, especially in asthmatics, is they may not seem outwardly like they're having respiratory distress, but they just can't get air in. They're air trapping. They can't get air out, so they're air trapping, and they feel like they can't get a deep breath. So on the surface, they may not look like they're in a lot of respiratory distress. So you have to take the patient's viewpoint of it on the severity. Listen to your patient and listen to what they're saying to you. The OPQRST, you can use that. Mnemonic here, onset, when did it start breathing, what were you doing when this difficulty breathing started. Like it says here, do you have a cough? Is it productive? Do you have a fever? So you're trying to sort of narrow the window down on the different breathing problems. You rate it. Do you have any problems anywhere else? You can do a scale of 1 to 10, but it's better to put breaths per minute or words per minute. It's a better indicator on their respiratory condition. And then time, how long has this been going on? How long you've had trouble breathing? All those are very important factors to look at. Then you want to look for altered mental status. Might have a cerebral hypoxia. This barrel chest we'll learn about in a few minutes on emphysema patients. You can go in Walmart and pick them out. The different COPDers, you can pick out emphysema patients and chronic bronchitis patients. Probably NCHFers, you can, if they're wearing something, you can see their ankles because they all have cankles and they all walk slow and they need oxygen. So you can go, your CHF, your emphysema, because you got that big barrel chest and that red face. Emphysema patients are historic for that because of the smoking. So, are they tripoded? Do they need to sit upright, like in a CHF patient, congestive heart failure? They won't lay flat. They've got fluid typically all the time in their lungs, and they don't like to lay flat. Are they retracting? Are they using those accessory muscles? Their abdomen, they're tugging at their neck, nasal flaring, right? Pursed lips. It's like, y'all know what that little goldfish looks like? Your lips look like this. That's to help them pull more air in. It's weird, I know. But they get those pursed lips. And again, how many words can they say before they stop? So observation, when you look at a patient having respiratory problems, your observation is very important, and then knowing the signs and symptoms. Are they pale, cyanotic, sort of a bluish tint to them? Are they flushed? Do they have a real red skin? Cyanosis, the first place it shows up is usually in the fingernail beds. So you look at their fingernail beds and then the mucous membrane in their mouth. So you have pull down their lip and see if they got some blue tint to them. This is a late sign. Cyanosis is a late sign of respiratory distress. That means they've been in respiratory distress for some time if they're already cyanotic. That's telling you that the cells are not getting enough oxygen. Pedoedema, edema, swelling, right? They have those cankles going on. They've got swelling in their hands. Sacral, where's that edema at? Sacral edema, where's that at? Where's that at? Yeah, around that area. Yeah, that's sacral area. That's like a question I heard yesterday on the radio. They're asking this lady, where was the Gettysburg Address delivered? Where do you think the Gettysburg Address was delivered? You know? She said Houston.
No, I didn't.
No, the lady on the radio said Houston. So where's the sacral edema? Where? That's right. Where's that at? Well, you're going here. All right. This would be abdominal. That's a sternum.
Okay. Your butt.
Your back, lower back.
Oh,
There we go. Coughing, are they coughing up anything? Are they coughing up those big lugs? You know, they have a productive cough.
Wait, how long does it take to become cyanotic?
There's not really a set time. It's some time though.
Well, obviously.
Yeah, I mean they've been through this process for a while. Do we hear different lung sounds? Audible wheezing, you don't need a stethoscope, that's why it's audible. But the wheezing, I've got a video, I'll show you guys a little bit over the different lung sounds. A gurgling or a fluid, snoring respirations, that's a sign of a partial airway obstruction of some sort. That airway obstruction may be fluid. Crowing, and I always forget this, I don't know why, but I think it's in pediatric patients where they move back and forth. You have to look that one up. I always forget it. And then stridor is sort of a harsh, deep airway sound, almost like there's an obstruction there. The sound you make when you cough up a loogie, you can get the go.
No, it's disgusting. That is
So, we're listening to those different sounds. In respiratory, here, with respiratory emergencies, probably the only one that's not, that you'll be able to do something with is the wheeze. What would you give someone that's wheezing, having an asthma attack? Albuterol, right, good. So you give them the prescribed inhaler or the updraft. The other ones you can't really do anything about unless it's a partial airway obstruction where you have to open their airway to get the snoring respiration.
You have to comment on controls to help them with it.
What?
You have to comment on controls to
Yes. So we'll get to that in the latter part. We'll talk about that on medical control, about the albuterol. All right. Listen for lung sounds. Make sure that you compare one side to the other. So when we practice, listen to the bases in the apex of the lungs. Up at the top, you hear the more of the airway sounds in the back. So if you're able to listen, if you're able to get to the back, listen to the airway sounds in the back. You lose about 30% of the airway sounds on the anterior side. So try to listen to the posterior when you're doing auscultating for lung sounds. The wheeze, that high-pitched sound, it's created, like it says, by moving air through a restricted device. You can create a wheeze by taking a straw, pinching the straw and blowing through the straw. Will create a wheeze. You get this crackles and bronchi here sort of by when the patient moves air in and out through the bronchioles. It's moving air through that fluid. Rails, if you want to practice rails, I don't see anybody that has a Coke can, but I'm not sure. You have to shake the Dr. Pepper up like that and put the stethoscope over the top, and that bubbles from the gas, from the CO2, you can hear that through a stethoscope, and it'll sound like crackles or rails, R-A-L-E-S. And it's just fine airway sounds moving through fluid. The other one is bronchi. Bronchi is air sounds moving through, air moving through fluid in the larger airways. And that sounds a lot like, is there anything in there? Blow air into it. Everybody's done it as a kid. Nah. You have anything in your tongue? Anyway, if you were to blow air, everybody's done that when they've blown air through a straw at some point in their life. So that is the sound, that bubbly sound is the sound of bronchi. That means that the fluid has moved up into the larger airways. It's no longer like rails in the smaller airways, but it's in the larger airways. And then the stridor, like we said, sort of that high-pitched, I'm going to cough up a Lug sound. And we'll listen to the different airway sounds here in a few minutes. When you go to assess the respiratory patient, make sure that you're always checking room air saturation. Take a minute, stick that SpO2 monitor on, see what their SpO2 is. What's the normal SpO2?
96.
Yeah, 90, 95, 96 to 100. So anything outside of there is abnormal. So if you get an abnormal SpO2 reading, you sort of have to start a checklist on why that is. One thing that you want to make sure that when you're checking the SpO2, that the pulse rate that's on the SpO2 matches the pulse rate that you took. It has to be pretty close. All right. Other things that can mess up your SpO2 reading: cold hands, fingernail polish, someone with bad circulation. So there's a few things in there that could sort of mess it up. But always check for a room air sat. This gives you a baseline to go off of, and you need that baseline when you apply oxygen, so you'll know if the patient's doing better. And then go ahead and apply oxygen. Here, we're just going to make a blanket statement to give everybody a non-rebreather. Put a non-rebreather on everybody. All your patients, put a non-rebreather on. When you do your clinicals and your write-outs, you have to discern between a nasal cannula and a non-rebreather. Right? Just remember the indications for a nasal cannula, which would be but there's a better. What's the indication for a nasal cannula? Huh? Yeah, they have to be breathing through their nose. Which that's a hint. So what would be the indication? Right, good. Mild respiratory distress. So an indication for a nasal cannula is mild respiratory distress, and they have to be breathing through their nose. They have to be a nose breather. What about a non-rebreather? What's the indication for a non-rebreather? Moderate or severe respiratory distress. And what liter flow? Yeah, No, that's not 15 o'clock, that's a bag valve mask.
10 to 15.
10 to 15, it says 10 to 15 here, and that's okay. But the goal with the non-rebreather, remember, is just to keep the reservoir bag full.
15 is the most.
Yeah, you blow up the bag. It looks cool, but it scares the crap out of the patient. They accidentally turn it up too much, it's just like a balloon. We'll blow one up one day and check it out. It looks cool. But 10, if you have to get up to 15, then you're probably going to start edging more towards a bag valve mask. All right. What's the liter flow for a nasal cannula? You got 2 to 4. Book says 2 to 6. Keep 2 to 6 in your mind for testing. But remember, practical aspects of it is 6 is too much. It'll dry out the mucous membranes. They start whistling in their nose. Again, it sounds cool, but it's really rough on the patient. Try it one day when you're there. Put a nasal cannula in and turn the liter flow up to 6. You'll see how irritating it is. All right. Everybody good so far? Any questions there? Yeah, a lot of that's still reviewed. So put them on oxygen. Get a room air pulse ox. Put them on oxygen. All right. If the indication requires the inhaler, go ahead and do that, or the nebulizer. All right. Non-rebreather. Or what they're looking at here is this thing called CPAP, continuous positive airway pressure. Last year, did anybody see anybody on CPAP?
What was it again?
It's that big mask that goes over.
Yeah, it's I think it's from one of their jails because they always have
Harry James, the old guy.
no, he wouldn't move.
Yeah, they.
He looked like he came
No, he
from.
might
He
have.
had it from straight too.
But CPAP, what they're doing now with CPAP, look at this in the hospital. When you guys do your respiratory clinicals at the hospital, I'm sure somebody will be on CPAP before you get out of school. So you'll be able to see someone on CPAP, talk to the respiratory therapist about it. We carry CPAP on the ambulance, but I've never actually put it on someone. What CPAP does is it delays the need for intubation. With these emphysema patients and a lot of the asthmatics, you really want to try to avoid intubating them. They're very difficult to get off the ventilator once you put somebody on there. So if you got a real brutal emphysema patient and you go ahead and intubate, well, not you guys, but if they go ahead and intubate that patient, it's very difficult to wean them off of that ventilator. So you may be signing them the rest of their life on a vent. So they're looking at this CPAP. They've been using it for a long time, and it forces air into the lungs. It works really good. It keeps a lot of people off ventilators. It's just not a really huge pre-hospital use for it. But in the hospital, most of the time they will try to put somebody on CPAP before they will do the intubation, especially CHF patients. It creates a lot of pressure in the lungs and opens up the alveolus, so it helps them quite a bit. But take a look at that during your clinicals. If you miss out and you don't, I've got an old CPAP mask around somewhere. I gave a class over it, and we'll hook it up on somebody. Blow their teeth down their throat or something. All right, let's look at some conditions right quick. All of these fit into chronic obstructive pulmonary disease, COPD. It's a very broad classification. Emphysema, chronic bronchitis, that black lung thing they always talk about, like with factory workers. Also, CHF fits in here, and asthma is also considered a COPD, but they don't necessarily list it there. With the exception of asthma and COPD, a lot of these, especially emphysema, they've come out and said that if you are a cigarette smoker and you continue to smoke, it's not the matter of when or if you get emphysema, it's when. And it's usually later in life, after years and years of smoking, and you can't go out and play with your grandchildren anymore, and or your older children. So cigarette smoking is very bad. I know you're trying to stop, but
I'm sorry.
keep going. Chew the Nicorette. There's a little commercial about it. Every time you feel the need to smoke, chew Nicorette. But very, very bad. If you're not smoking yet, stay away from it. Do something else. Here's a couple good lungs. Well, one good set of lungs to look at. Guess what the black one is? This is smoker lung here. These are pretty blown up with air, but nice, good smoker lung.
My science teacher showed us ones like that.
Got ugly tumor on it
Huh?
too. Got tumor on it too.
Oh yeah, there, yeah. Probably didn't survive. And then healthy lungs. Which one do you want? Right? Yeah. Yeah, you get the black ones. Yeah. And all right, let's look at chronic bronchitis right before the bell rings. Bronchioles, they get inflamed. You get this excess mucus production, all right? And there's a picture on the next slide, I believe, yeah, where you get this excess mucus production in this chronic bronchitis. This bronchitis, probably everybody's had bronchitis, inflammation of the bronchioles, but the difference between here, they're always chronically inflamed, but they start making this very, producing this mucus that lines those bronchioles. The problem is what? With all that mucus in the bronchioles. You can't hear. You're saying something. I can't. What? Yeah, diffusion is a problem. If you get it down the alveolus, you can't diffuse with that mucus in there. That's correct. And then air trapping. Air won't. You're going to have higher airway pressures. You're not going to move as much air. These chronic bronchitis patients are usually the ones that I've encountered. They're usually overweight. They're sort of big and puffy, and they're always sweaty for some reason. I can't figure that out, but they always have. They look like they're sweating, and they require. They're not as really bad as the emphysema patients, but they require most of them to have oxygen. These guys, these chronic bronchitis patients are just sort of sickly looking all the time. It's hard to describe. When you see them in the hospital, the face would be big, just sort of cyanotic somewhat. They have a blue tint to them. All right. Questions there? Everybody good?
Whoa.
No.